Good afternoon. My name is Joe Sam Robinson. It's my pleasure to have with us Dr. Lahoti, who has joined our practice in Macon to look after stroke problems. And he's a gentleman of great repute, many good accomplishments, and so we're delighted to have him here. And I don't know if stroke has had enough attention in this part of the world, but I believe Dr. Lahoti is going to correct that, and so I will give you the football, Dr. Lahoti, and we can illuminate the issues.
Thank you, Dr. Robinson, and I'm glad to be back in town as well. I used to be in Macon until 2020. From 2017 to 2020, I spent 3 years in Macon developing a stroke program at what used to be Coliseum Health Centers. And after that, I went on to do specialized training in endovascular neurosurgery or interventional neurology up in Iowa. And then after that, I was in practice for 3 years, and now I'm back here to start a program at Navicine Medical Center to provide this very much needed service, which has been lacking in this part of the world.
That's a big problem, is it? I mean, going finally to a
Mhm.
comprehensive stroke center. So if you look at the map of Georgia, there's a big
Mhm.
area right in the middle of the stroke belt where
Mhm.
that service is not available.
Mhm.
So with great efforts, we
Mhm.
were trying to establish something like that, and I believe it'd be really a good thing for the citizens of this part of the world.
It certainly would be. And to explain some of that, I have a presentation here, and we can go through the slides to basically talk about what exactly stroke is and what we can do to help people who suffer from this very disabling and deadly disease. So if you will, stroke is essentially death or damage to the brain tissue resulting from interruption of blood supply. And there's another term called transient ischemic attack, or TIA, which some people like to call mini stroke, which is a temporary loss of brain tissue due to reversible interruption before the death of the brain tissue. So a lot of times TIA is a precursor to the stroke itself. So if you have a TIA, it's just as serious as a stroke. And that needs to be addressed immediately to prevent from having a permanent brain damage.
That's a big deal, isn't it?
Absolutely.
So people, are they aware enough of what these TIA symptoms are, and do they know what to do enough?
Not everybody. And that's the part of the problem as well, because unlike a heart attack where there's chest pain and some really strong discomfort, a stroke doesn't usually produce any pain, and people usually tend to neglect it or wait on it for a little while before they would actually show up to an emergency room or to their doctor's office. But as we go through it, there are two main types of strokes. One is called hemorrhagic stroke, and the other is ischemic stroke. Ischemic stroke is due to a blood clot, which stops the blood flow to a part of the brain. And the hemorrhagic stroke is due to rupture of a blood vessel in the brain, which leads to bleeding in the brain. And so these are the common signs and symptoms of stroke. And the best way to remember them is to remember the acronym FAST, F-A-S-T. F for face, where there would be drooping on one side of the face. There would be weakness of the arm and leg on one side. There will be problem with the speech. Either there's difficulty coming up with words or difficulty talking clearly. And T is for time, because stroke is a very time-sensitive disease, and the sooner you can get to the hospital, the better we can fix it. And here are some of the statistics about stroke. Strokes takes a life of about 140,000 Americans every year, and it affects almost 800,000 Americans every year. Someone has a stroke every 40 seconds in the United States, and every 4 minutes someone dies from a stroke. And having had a stroke previously or in past is a big risk factor for having another stroke. So up to 25% of people who have a stroke have had a stroke in past. And it's a very expensive disease. It's estimated it costs up to $56 billion every year to the federal government. And it is the leading cause of long-term disability and the fifth most common cause of death. And disability, the kind of disability which comes from stroke, sometimes it's even worse than the death. Mm-hmm. So it is a very serious disease, but the good thing is we have treatments available for it now, and I'll speak about it in a little bit. Now this is the stroke map of the country. And as you could see, the darker areas are the area where the prevalence of the stroke is the highest. And you would see we are right in the middle of the stroke belt there. The states of Georgia, Alabama, Mississippi, Tennessee, they have the highest prevalence of stroke in the entire country.
Is there a dietary connection there or maybe a hypertensive connection?
Absolutely, both. So that's a common question asked, that what leads to formation of this or the stroke belt. And so here are some Georgia specific stats. So Georgia has the 13th highest stroke death rate in the United States, and it costed the state around $2.5 billion every year. And then it's in the middle of the stroke belt, as we spoke about, where the death rates are approximately 30% higher than rest of the United States. And the coastal plains of Georgia have even higher than that, which is up to 40%. So why is that? As you mentioned, one is the southern diet. So fried chicken, pork chops, they are very good for the palate and tongue, but they're not very good for...
Lots of grease.
Exactly, all the grease.
Lots of grease, some greasy French fries in there.
Exactly. So those are not good for your heart, your kidneys, and for your brain. And that's what causes this higher rate of stroke. And the other reason the death rate is so high from stroke in Georgia is access to healthcare. So this is a map which shows where the different stroke centers are located across the state. So what we need is to provide comprehensive care for stroke is a comprehensive stroke center. So those yellow pentagons there, they denote the comprehensive stroke center. And you would see there are only 8 comprehensive stroke centers in the entire state, and majority of them are in Atlanta, with just one being in Savannah and the other one being in Augusta.
Well, what can I know you'll speak to this, but what can a comprehensive stroke center accomplish that doesn't happen elsewhere?
So I'll get to it when I basically talk about the treatment of stroke and why is it that important as well. So first, why is it important to have stroke center or comprehensive stroke center closer to home is because the treatment of stroke is very time sensitive. So this was a paper from UCLA where they studied the rate of loss of brain cells with time after somebody has a stroke. And they actually quantified it. And they found 1.9 million neurons, meaning about 2 million brain cells die every minute when somebody starts having a big stroke. So every minute is important. So the closer you can get to the hospital and faster we can reverse the stroke or remove that blood clot, the less the damage would be to the brain. So the problem with Central Georgia is that we don't have those comprehensive stroke centers anywhere in the Central Georgia. Right now, the standard of care is that if a person has a stroke which needs a surgery to remove the blood clot from the brain, they have to be flown to Atlanta, which takes several hours for them to get there at least. And by the time, it's not uncommon that by the time the patient gets there, there has already been significant damage to the brain. And then that surgery either becomes futile or sometimes they don't even do it because there isn't much brain tissue left to be saved.
And so the referral pattern is also an issue of consequence. So having a comprehensive stroke here is also going to require a relationship with all those outlying hospitals to respond to this issue in a very, very timely fashion. And the location in Macon will be a great advantage.
Yes, absolutely. And that's what we plan to achieve in Macon with partnership with Navicent, that we would have a comprehensive stroke center. So not only patients coming to Navicent Medical Center could benefit, but all the surrounding hospitals could as well. And that will substantially reduce the time it takes to transport somebody from what we call a primary stroke center to a comprehensive stroke center.
And so one of the issues that appears in the state is sometimes a hospital chain will try and keep their patients in their network. But a stroke is something that it won't work with. You've got to get the timeliest place to go. The patient needs to go there.
Absolutely.
And that's no delay is acceptable.
Yes, absolutely. And that would be of a very significant detriment to the health of a patient. If a hospital system chooses to transport a patient not to the closest comprehensive stroke center, but somewhere else where the hospital is affiliated with them or is part of the same healthcare system.
Indeed, in Georgia, the issue about acute care, I mean, the idea is time is very, very important for many kind of medical problems. And so the system needs to be refined in the state, I think, to get anyone with a number of problems right away, expeditiously to the best place for them. And this, I think, will require some effort on the part of the state legislature. That's my thought about it.
I believe so, but we'll see how this all pans out after we have the comprehensive center. We'll talk to the hospitals around us and see how they respond to it.
Yes.
So then how do we treat stroke? So there are two main ways we treat the stroke. One is to give this medicine called TPA, so popularly called as clot busting medicine, where it's given through IV. It's a very strong clot buster, and it would circulate through the blood, get to the brain where the clot is, and try to break it. So for the longest time, we didn't have any treatment for the stroke. But this drug got FDA approval for use in 1995. And since then, the use of it has expanded quite substantially. However, the problem with this is it only works about 20-30% of the times. And it can only be given within the first 4.5 hours of start of stroke symptoms. And as I was talking to you earlier, that there are only a small proportion of patients who realize that they're having a stroke and they realize the importance and urgency of it. So it's not uncommon for people to not know, and even if they know, they would want to wait on it and see the symptoms get better, and they may come to the hospital after several hours or the next day. So it's estimated only about 10% of patients who have stroke actually end up getting this drug, because the time period of that it could be given is so short.
Yes.
One. And the second is, even if of those 10% who get this drug, it works in only 20 to 30% of them. So there's a big pool of patients who don't receive this drug at all. And that's when the second and the most effective form of stroke treatment came into being, and that's called thrombectomy. In thrombectomy, what we do is we go from the blood vessel in the leg and take our catheters all the way up to the brain and mechanically or physically grab that clot with a stent and remove that clot out. So the success rate of thrombectomy is much higher. It's up to 90%. The 90% of the times we're able to get the clot out. And it can be done up to 24 hours from the stroke onset.
So during that 24 hours, presumably a lot of brain cells died.
Yes.
Is that right?
So though we can do it up to 24, but the sooner a patient comes to the hospital, the higher will be the chance of success.
There's a penumbra, in other words, which you may speak about, but there's these cells that have, some of them are just, the light went out, and some of them, they're still glowing a bit. They're still not totally dead, and those are the ones that can be saved with long,
so that
sometimes
is
longer than you think.
Yes, absolutely. So that's the basic principle for doing thrombectomies, that there is a time gap between the brain stops working and brain cells actually die. So if you're able to restore the blood flow in that time period where there is loss of function of brain cells and the actual death of the brain cells, then we could gain those brain cells can gain their function back.
And so that's a big deal. I mean, just understanding humans. I mean, people, oh, my arm, I can't move my arm well. Who knows? Maybe I'm going to go to sleep. I had a little too much beer, and oh, it still doesn't work. And so they're obviously far advanced, but still salvageable.
Yes.
Still salvageable. So people should be aware of that.
Yes.
There's hope to get this thing reversed.
Yes. So because with thrombectomy, we were able to expand the window up to 24 hours, now vast majority of the stroke patients now could be treated. Now, is the treatment successful in all of them? The answer to that is no. And in patients who we do this, about 50% of them are able to go back and work independently. But 50% still have some sort of disability left. But after the thrombectomies, our death rate and mortality from stroke has substantially gone down.
So that's a big triumph, and you're getting better and more artful at this every year. So this is a big thing, and putting a really contemporary system in Georgia will be great.
Yes,
but we're right in the middle of the stroke belt. We can really help people.
Yes, absolutely. So, and this is where the answer to your question is: what are the different kind of stroke centers? So there are primary stroke centers, and primary stroke centers are the ones who do this drug, the TPA, but they cannot do the thrombectomy. They don't have the facilities or the doctors who are able to do the thrombectomy. And places who are able to do the thrombectomy are the comprehensive stroke centers. And so we don't have any comprehensive stroke center in Central Georgia or South Georgia.
Yes.
So that's where we are basically working to fill that very big need and void.
That's just the part of the world where people eat too many pork chops and don't take their hypertensive medicine.
Yes.
Is that correct?
Yes. That is true. So, but the thrombectomies have completely revolutionized the stroke care. Because when it really works, it's no short of magic, where you have a patient who come in with complete one side paralyzed and not able to talk at all from a stroke. We remove the blood clot, and the very next minute they're able to move their arm and leg again.
It's very gratifying, isn't it? When people can be saved, and that's literally what happens.
Yes.
A life of aphasia, a life of paralysis is a terrible.
Absolutely.
Now, what can I'll ask this question: what can be done to prevent strokes? But with Medicare, what should a person on the street think about? You got obviously there are many things that put their welfare at risk. I mean, walking carelessly down the street, drinking too much alcohol, whatever. But are there some medicines they can take, or should they be taking aspirin, for instance? Comments on that?
Sure. So I have this slide for that. So there are 8 habits you could do to prevent a stroke. Be active, quit smoking, eat right, as we talked about, keep your blood pressure under control, take your medications regularly, and limit drinking. Now, the most common risk factors for the stroke are high blood pressure and smoking, cigarette smoking. Then the others are diabetes, high cholesterol, obesity, and The good thing is that these are the same risk factors for your heart disease as well, for your kidney disease as well. So if you do these things, you'll save not only stroke, but a lot of other health problems as well.
So a person that's had a TIA or a stroke, they really need to be worried about their whole vascular system,
Yes.
Their heart, their peripheral arteries. So it's a ubiquitous problem. Totally in the body. And really, a lot of this, I would think, is really good primary care. Getting some really good primary care to shepherd people through these dangerous times. Yes,
that is very true, and that's a good thing about stroke. Like say, as opposed to some other diseases like cancer, where a lot of times you can't do much to save yourself or prevent a cancer. For stroke, it's in your hands. If you do the right things, take your medications right, take care of the medical problems which cause a stroke, you substantially decrease the chance of having a stroke. And that has been the biggest reason why we see stroke so prevalent in this area.
Is there a connection between many other variables? So, for instance, access to primary health care, maybe people don't have insurance. There are many reasons they've fallen through the cracks. That's a societal problem. They need to find a way to maintain their health, and that would be important. Primary care people are important. Yes. And are there some complications? Maybe you have a complication slide, I don't know, of the thrombectomies. You have some things not always perfect,
yes,
but what could happen?
So the biggest thing which can happen is when we go up to the brain to try to fish this clot out, we are in very tiny blood vessels, and they don't look as pretty as they look in this picture right now. So we are in blood vessels which are 2-3 millimeter in caliber, and when we are trying to grab that clot, sometimes we can perforate that blood vessel, and if we do that, there's going to be big hemorrhage in the brain, which could end up making things worse than what they are. There could be injury to the blood vessels we are passing through, and that can cause something like a dissection in the neck, or sometimes the blood vessels in the brain. Other times, after we open the blood vessel and the blood starts flowing through, it's like opening the floodgates. And if there's a lot of damaged brain tissue already and we have opened the floodgate, the tissue is in there to use that blood, and that can cause to have hemorrhage, what we call reperfusion hemorrhage. So those are some of the problems which can happen with stroke. But now, as we have done more and more of these, we've got better experience, and we've got better tools as well to do this. It's great. About 90% of the times we're successful in taking the clot out without a major problem.
And so other things can happen with these patients. Many times they're in frail health. They have heart problems, coexisting heart problems. Other events take place. Often they can be quite sick and require an intensive care unit environment, hospital resources. Well, this procedure and abilities to do these life-saving events cost money. And it costs some money, but it saves money, does it not? So it's a good investment.
Absolutely. I mean, it saves a lot more money, and it saves a human life.
Yes.
Compared to what it costs. But yeah, costs definitely, they're more expensive than the medications or some of the other procedures out there, because this technology is new, and there are patents on these technologies. But they make a substantial, a very significant difference in a person's life, as well as the amount of time a person or a patient spends in the hospital.
And also their families.
Yeah.
So if somebody is devastated, their family, and it's extremely expensive to the family and to society. And so the money that's used to accomplish this is really well spent. I think it should be considered an investment.
Oh, absolutely. The reason I got into doing this was that when I was a medical student, I saw two stark examples of, and opposite examples of a person who could receive a thrombectomy and who could not. There was a 39-year-old lady who had a stroke and could receive the thrombectomy, and the next day she was able to walk and talk again.
Yes.
And there was a 60-year-old gentleman who had a stroke but couldn't get to the hospital in time and couldn't get this therapy. He was left with paralysis on one side of his body. He's lost his ability to speak. He had to be cared for by his son for the rest of his life. And that was a very substantial burden, not only financial, but physical burden on the family
the whole
as well.
family is really, devastated.
Mm-hmm.
Well, are there new progress out there? I mean, what's in the hopper that might make things better for strokes or earlier detection? I mean, what can we do to be aware of the possibilities for this happening? Any comments?
So there are several different things going on, and they're targeting different aspects of what causes a stroke. So apart from the risk factors I mentioned, there are better drugs to manage those risk factors. Then one of the common conditions which causes a stroke is called atrial fibrillation, or AFib.
Yes.
It's an irregular heartbeat which causes clots to form in the heart, and these clots then travel from the heart to the brain to cause a stroke. Now there is better technology to detect atrial fibrillation early, so that either it can be treated and completely fixed, or patients could be put on stronger blood thinners so that they don't develop these clots.
Sometimes the side effect of that is they can just have primary hypertensive hemorrhage. So sometimes that happens with.
That has been studied, and there is a higher risk of hemorrhage when somebody's on a stronger blood thinner, but the impact it has in reducing the incidence of stroke is far greater than the risk of having a hemorrhage from that.
Yes. So one of the things to think about is atrial fib. I mean, it's people are maybe not even aware they have it, and now I think you can get wristwatches that will show you something about that. But certainly it's something that needs treatment, and there can be aggressive ways to stop the atrial fib, and so those are good advances out there.
Yes,
that's a nice thing.
That is true, and there has been a big focus on improvement of overall cardiovascular and the cerebrovascular care and preventive care as well.
Yes.
And so we're targeting it from all sides. Preventive aspects of it, then if you do have a stroke, then the treatment aspect of it, and the recovery and the rehabilitation aspect of it as well. So that has also made a substantial difference in how well patients are able to do now compared to, say, 10 years ago.
Yes. What would be the follow-up after? How would you follow your patients after you've had this event?
So typically we see patients soon after they're discharged in a week or two to make sure that they're okay at home, they're taking their medicines right, and address any questions they would have in the hospital or leftover problems from the hospital. And then we would see them in the clinic after 3 months.
Yes.
And at the same time, during the same time, we'll coordinate with, usually they need some sort of rehab from the stroke. So either they go to a rehabilitation hospital or they get outpatient therapy. So our office will coordinate with their rehab hospitals or their outpatient therapists to make sure they're getting appropriate therapy.
Well, I see that our time is about finished. Thank you for your insightful comments about a terrible problem. And we look forward to many good years of you in Macon looking after many, many sick patients. So thank you for your good offices and presence here. Thank you.
Me too. Thank you, Dr. Robinson, for having me.
Thank you, sir.